Welcome everyone to our first inaugural eSOSORT webinar titled Physical Therapy Scoliosis-Specific Exercises, PSSE, in growing children with adolescent idiopathic scoliosis and hyperkyphosis. PSSE is characterized by special exercises that are specific for every curve type and every individual. It had its origin back in the 1700s when people with spinal deviation were treated using specific gymnastics. More than 2 centuries later, we are still working to improve the exercises through our best presenters that you're going to have in this webinar. I would like to introduce our webinar moderator, Joe O'Brien, the President and CEO of the National Scoliosis Foundation, where he has been a board member since 1978. He was elected as an honorary fellow member of the Scoliosis Research Society in 2006 and has continuously served as an advisor to their health policy, patient education, and non-operative committees. He is also a past president of eSOSORT and hosted the first international meeting in the US in 2007. Joe is also a patient who had had 6 surgeries for his scoliosis. He is one of 15 family members with adolescent idiopathic scoliosis, including 3 of his 5 children.
Thank you very much, Higit. I truly appreciate being here today and welcoming all of you to this presentation this morning, which is being hosted by eSOSORT on PSSE as an eSORT for 2021 and hosted by the Education Committee and the co-chairs Asanya Schreiber and Higit. Higit is a physical therapist who focused a career on the development of care centers for scoliosis and other spinal conditions. She co-founded 2 scoliosis and spine care centers in New York City, with the first at the Hospital for Special Surgery in 2010, and the second at Columbia University Medical Center in 2013. She has been a eSOSORT member since 2011 and is currently co-chair of eSOSORT Education Committee. She has taught and mentored physiotherapists all over the world, authored papers and case studies, and co-founded the Scoliosis and Spine Online Learning Platform to deliver online learning to healthcare professionals in the field of scoliosis. Hagit is the owner of Shroth NYC Clinic in New York City and Good Posture in Israel. Dr. Berdichevsky has no financial disclosures for this presentation. As we have all experienced during this past year, a pandemic has rocked our world. It has brought us sadness. It has brought us challenges like we've never seen before for any of us who are alive. It has also brought new normals that we have to look at and new challenges. It is also that challenges has presented itself within the world of scoliosis as well. Today, we have an opportunity to look at that. Just by virtue of the fact that we have to make this a virtual meeting shows one of the challenges that this pandemic has brought to us. But I'd like to go over some of the details for today's webinar to help you as we go through. As you know, in the agenda, we have 2 presenters today, Eric Perront and Sabrina Donzelli, and then that will be followed by 4 presenters in a roundtable format. Their presentations will be pre-recorded just by virtue of time. That will make it a little bit easier to make sure that your time this morning is worthwhile and that we honor that. Because of the amount of people that we have here, and we thank you all for joining us around the globe. This will be a Zoom session that will be in a listen and view mode only. So you'll have no mic or chat that you'll notice on the bottom so that we can keep on time. There is a closed caption session though, since we are globally, and it may be difficult for some of those who do not have English as a first language or primary language. The closed caption you can find within the live transcript session. And if you pull that down and then press on that first screen, then you'll be able to follow the closed caption, both for the presentations and as well as the live sessions. And we will have a live question and answer sessions today. There will be one after Dr. Perront and Dr. Donzelli, and then we'll have a final one after our roundtable panel. As anybody who has attended any presentations in the past, this could be some of the most important time of the presentations is actually the questions that we ask. There's no need to wait to the end. We invite you to please put the presentations on as you think of the questions. Put your questions up there, for the presenters. So we'll go through. There will be Sonia and Hagit will be going through and trying to highlight those questions. We anticipate we're going to have more questions than possible to answer. We are graciously, the speakers have agreed to answer those questions that we cannot get to today. They will answer in the next coming weeks so that everybody will hopefully have their questions answered by the end of a couple of weeks. As Hagit said, I am the president and CEO of the National Scoliosis Foundation. I am honored to be part of eSOSORT and the SRS. I am also an advisory panel member and patient representative for the U.S. Federal Drug Administration, both on the device and radiological and the drug evaluation and research side. I have no conflicts for this presentation. In my capacity as the National Scoliosis Foundation CEO, our mission is to improve the lives of people living with scoliosis. We do that by advocating for early detection, raising awareness for scoliosis and optimal care, providing lifelong patient support in a number of different ways, and serving the entire scoliosis community from professionals to patients. We believe that every child, regardless of race, creed, or socioeconomic status, deserves an equal opportunity for the early detection of scoliosis and the least invasive, less costly, most effective evidence-based treatment options possible. As Hagit said, I am also a scoliosis patient who has had a 55-year journey with 6 surgeries. The 6th one was 3 years ago, pre-pandemic. Nonetheless, this is not an indictment against surgery. Surgery is necessary in some people, and the other part of my journey shows that it's been incredible innovation from the first time in 1966 to the last one in 2017. However, at the end of the day, it has presented itself with over 600 days of absence from school or work and over a cost of over $800,000 US. So there is clearly a better option that we should look at as a first course of treatment. That desire comes very true in terms of the capacity of being a parent or grandparent and looking at someone who you love. In our family, we have a very high penetrance where we have 15 family members with scoliosis, including 3 of our 5 children. We have had 4 who have been braced, and the majority of them have stayed with below 40 degrees now, but nonetheless, we are fortunate in that capacity. However, every day we wonder, during the pandemic, we had 2 more grandchildren. We now have 11 grandchildren. 2 more were born. And it's not a day that goes by that don't worry about what's the best treatment for them. Are they going to be the next ones to have it? What can we do about it? And the problem is despite us being from 1700s, as Hagit said, and despite being in Hippocrates and before that, despite everybody looking at it, we still have the same dilemma with adolescent idiopathic scoliosis. We don't know who will get it, why they get it, who will progress, when they progress, how far they progress. We do know, though, in certain cases, it will progress, as this child on the right who has a 115-degree scoliotic curve. We also know that there's a very short window that we have to respond to it. As Duval Papier and others have shown in her 1972 study, when we look at the curve in terms of growth velocity and the severity of the curve, it's a very short window. And growth doesn't happen textbook. It happens very quickly. We have a 3-dimensional spinal alignment problem, structural problem, that then has a 4th dimension with time that we have to respond to. Based on the work from Dr. Weinstein and Ponseti in 1983, who was published, they looked at curve progression in a their seminal long-term series of follow-up with patients. And they showed that when you reach skeletal maturity, if your curve is less than 30 degrees, then you have a very short potential of continued progression into adulthood. However, if that's a larger curve in the 50-degree category, then we have a very high risk for continued progression. Prevention is absolutely essential. We've seen in this last year that wearing our mask, being socially distant, washing our hands, perhaps seems small to some people, but in reality, it's saving lives. We see the same thing that's happened in many other things throughout our life. Ben Franklin in the 1700s said an ounce of prevention is worth a pound of cure. He was talking about the fire prevention in Philadelphia. Well before him, a Dutch philosopher, Erasmus, has said the prevention is better than cure. In the world of scoliosis, we see that very much so. And this screen here with our patient needs versus the patient care that's provided, this helps us to get an understanding of what really optimum care is. To be optimum care, we want to match the patient need with the care that's given at the time that it's needed. So that the patient who is just in a small 10 degrees or more, that maybe just in an observation or is older, et cetera, we have in here if we match them within that category. On the other hand, for those that are progressing and PSSE is appropriate, then we want to match them at that time, and so on and so forth, to brace and to surgery. We find that if, in fact, we don't match them, if we hold on to those patients too long, or we don't get to them at the right time, then we end up either undertreating them or overtreating them. In essence, when we look in today's world and pandemic, PSSE and the physical therapists who provide it are truly our first responders. And we thank them for that and want to help them to do their job. I was asked to look at patient perspective, and we don't have a lot of time to do that. But in reality, I would say that it actually is about relationship. If we're going to have evidence-based positive outcomes, we need patients who are compliant, that make informed decisions. We have to engage that patient, educate them, and empower them for whatever it is. That requires relationship of trust. That requires a patient who's going to believe that they have a clinician who is going to do the work necessary to understand the treatment and to apply it at the right time and at the right place for that child, not hold on to them, not make it look like they're thinking more about money than they are the patient. We need to be able to make sure that we consider the whole person, not just the spine. At the end of the day, perhaps one of the most important things for our mission of early detection and SOSORT's mission for that treatment is, in fact, evidence-based outcomes. We are fortunate in 2013 with Dr. Weinstein and Lori Dolan and others with the BRACE study that gave us level 1 evidence for bracing as early treatment. We need to have that same type of evidence, if possible, for PSSE. The more that we can show that we have truly positive evidence outcome at the end of the day, then that will give comfort to the patients, it will give comfort to the policymakers and the insurers, all the way down the line so that we can provide the continuum of care that's necessary. With that being said, I'd like to introduce Eric Perrant, who is the current president of the Society on Scoliosis Orthopedic and Rehabilitation Treatment. He is Associate Professor of Physical Therapy at the University of Alberta in Edmonton, Canada. Dr. Perrant's research focuses on documenting the effect of physiotherapy and scoliosis-specific exercises in patients with scoliosis and in documentation the measuring properties of outcome measurements for monitoring the effects of non-operative treatment. His research on these topics has been awarded many times at the SOSORT on 3 occasions specifically. Dr. Perrant is also a member of the SRS non-operative and research grant committees, and there is no disclosures for this presentation.
Hello, so it's a pleasure to introduce you to an overview of the current evidence on PSSE for adolescent idiopathic scoliosis and those with hyperkyphosis. As disclosure, I am a researcher that does research on exercise. I have certified in TROP, and I am the president of SOSORT. Let's begin with a short definition. So the PSSEs, they are the outpatient exercise therapy that we individualize to each curve type in order to have some, hopefully, of the published positive effects. All the PSSEs typically share that we teach the patient an autocorrection in 3D. We teach them to hold that posture with their muscle training and then educate the patient to hold these corrections in their daily life. Evidence on this topic mostly started with a systematic review in 2008 by Dr. Negrini. At that time, there was only one RCT. There was evidence about 5 SHROT studies, some side shift studies, Lyon, CS, Dobomed, and some Chinese study. Generally, the evidence was positive, showing that it led to less progression in patient treated with intensive inpatient SHROT or with outpatient rehab, and the follow-ups varied from 6 weeks to 15 years follow-up, which was quite good. We then described in more detail these exercise approaches in a paper by Berdychevsky in 2016 in Scoliosis. You're welcome to go review a lot of those descriptions. At this stage, we now have some of the leading spine societies stating with a position statement that they believe in the recent high-quality studies that show that non-operative interventions such as bracing and PSSE can decrease the likelihood of curve progression to the point of requiring surgical treatment. So there is now embracing some of that evidence. So what is the evidence? In 2012, there was a Cochrane review, which is now being updated by Romano, that found 2 controlled studies. So it was more restrictive because they only included controlled studies. The first one was the Chinese trial showing that exercise helped reduce curve angles in double curve over 6 months. And then the other one was a very low quality 1-year prospective controlled study showing that CS scoliosis specific exercise was better than usual physiotherapy at preventing brace prescription. So that was promising. More recently, there was a US task force focused on determining whether they recommended screening for adolescent idiopathic scoliosis. As part of that, they did a review. They found 2 studies. The first one was a more recent RCT by Monteconi that showed that supervised exercise in the CS type led to better Cobb angle, angle of trunk rotation, and SRS-22 scores at maturity. So it's one of the most influential studies as it is following patients up until maturity. The control trial we just described was also included in this review. Still, they concluded that we needed more info about the effect of exercise in patients that are detected with screening program. These was not the case. And they also say we need evidence about the effect of exercise in adolescent in order to influence what happens in adulthood before we can justify a stronger recommendation for screening. Since 2015, there have been 10 systematic reviews published on the effect of exercise for scoliosis. Those highlighted in green are showing positive results, those in yellow, less so. What we find is that these are quite heterogeneous. There's 2 to 9 more studies, depending on which ones we look at. There's only 2 of those that are fully covered by the studies included in other studies. So they contribute something different. And sometimes it's different comparison interventions. Sometimes it's different duration of the trials. Sometimes it's more or less intensive therapy. So there's differences there. When we try to break it down, what we find is that combining all of these studies, we are able to inventory 45 studies on PSSEs. There's 19 of those that focus on some form of SHROT therapy, including 12 RCTs, but those are mostly short duration, with the majority of them, 17, less than 6 months long. Still, there are 2 studies with over 6 months follow-up. For CS, there's 8 studies of those 4 RCTs, and there are here 4 studies that are followed up more than 6 months. There's a number of other PSSEs inventoried in there. There's a study on side shift, on Mézières, on Ximayo, which is a Chinese approach, exercise on whole body vibration specific to scoliosis, or the Chinese trial we talked about. 2 of those have long follow-up. And then there's a number of other trials we would have to dig in a little bit deeper to figure out if they are PSSE or not. One of those is a longer follow-up. So if we take those reviews and try to see the most recent ones, what they say, the recent review by Lee shows that there was 6 trials, 5 RCTs. The exercise duration were varied from 6 to 48 weeks long. Typically, the studies did not report on compliance, and their quality was 2 have a low risk of bias, so good quality, 3 was unclear, and 1 had a high risk of bias. They compared to different intervention illustrated here, and they find that overall, overall, these studies had improved the cob angles when you combine all the exercises. And here they had focused on core exercise and PSSEs. The results were quite heterogeneous, so they tried to break it down. They found that the studies that focus only on PSSE had results that were more variable and not quite significant despite being positive. And they raised the issue that there might be a possible publication bias where more of the studies with positive results get published and maybe some evidence is missing to have a clear distribution of the results. So let's keep that in mind. The effects were positive from all these exercise studies on the quality of life measured with the different scales. It was not having significant effect on the angle of trunk rotation or on the SRS-22 pain scores. Another, almost at the same time, review by Yunli Fan showed that there was 8 RCTs and 2 control studies. She assessed the quality using the Pedro score and found an average of 6.9 out of 10, which is moderate to good. The 5 studies that reported compliance showed that it's possible to achieve good exercise compliance with results in the 62 to 88% range. The results were too heterogeneous to allow meta-analysis because they focused on different exercise types, different comparison intervention, different doses, or different follow-up durations. Still, they demonstrated that the effect were generally positive on the cob angle, with 5 moderate quality studies showing significant curve reductions in the ranges illustrated here, with follow-ups that varied from 10 weeks to 42 months. There was 3 RCT with significant reduction, but that were not quite as important. And the results are illustrated here. And these were typically a little bit shorter duration. And then there was 2 RCTs where the results of ASSEs were good, but they were not as strong as with bracing combined with the exercise or with bracing alone. When they compared the results for truncal asymmetry, they found that only 2 of the 6 studies improved the angle of trunk rotation, and SSE was not better than some other active treatment for these parameters. The quality of life was improved in 3 of the 5 studies that PI baseline score, especially for function and mental health. And the studies that did not find differences were comparing to bracing or to active home programs. Another review, I continue comparing them because they overlap partially only with different studies, included 4 RCTs and 4 controlled trials, moderate Pedro score. Again, the heterogeneity prevented pooling, but the conclusions were that the SSEs were superior to no treatment for curve angles, superior to standard exercises, with 5 studies showing results, and 3 of those were significant effect that were in the moderate to large range. And unfortunately, at this stage, there was still no study comparing different PSSE methods. We now have 2 meta-analyses on SHROT. They don't overlap perfectly, so I'll review both of them. The first one by Berger referred to 3 RCTs with a 5 to 8 on the Pedro scale, with follow-ups of 1.5 to 6 months long, comparing to different intervention. They generally find that the cob angle can be reduced over a period of 6 months. The results favor the SHROT intervention compared to the controls. And when comparing supervised to unsupervised programs, supervised get better results. In terms of quality of life, the results were improved with moderate to large effect sizes at 12 and 24 weeks. In the other study, we found 5 RCTs and 1 control trials in adolescent. They reviewed a lot more, but those were on adolescent. The follow-ups were from 3 to 12 months, comparing to various intervention. And then they did pool the results to do meta-analysis and showed that the results were better in teens than in adults. The effects were best if treating smaller curves at baseline and offering longer treatments. And when comparing different types of SHROT interventions, the programs that were most comprehensive compared to those that were simplified had better results. And then the effect sizes were moderate to large on a variety of outcomes, including the cob angle, measures of asymmetry, trunk strength, quality of life, and lung measurements, including balance and pressure measurements. At this stage, we still do not have evidence whether exercise offered in patients with large curve would be better or similar to surgery, so that's not available. And so we invite you to refer to different recommendations on how to standardize research to address some of the issues in the previous studies. For example, it's hard to verify if authors do selective reporting because a lot of those studies were not previously registered. There has been some suggestion from a study by Fishman that side plank might be useful, but a more recent study showed that the effects were not significant. So this simple approach does not appear to offer benefits. So in conclusion, for AIS, we find that we have moderate quality evidence that support the use of exercise. We need more high quality evidence, especially with regards to long-term health outcome that from adolescent treated that would have benefit in adulthood. And we invite authors to focus on reducing the heterogeneity by focusing on our recommendation. But what about the effect of PSSEs for hyperkyphosis? There was a systematic review that found despite finding 10 studies, only one of those was focused in adolescent, but in adults, the effects were typically good, reducing kyphosis, not so much to affect the lordosis. And it appears that strengthening approaches were better than stretching. When we look at what's available now in terms of individual studies in adolescents, we have 2 RCTs and a cohort study and a controlled study focused on slightly different types of patients. One uses SHROT, the other ones use more traditional exercise, and the follow-ups are from 3 to 6 months. We find that the first study showed significant effect on kyphosis and also improved self-image, but not other domains of the SRS. The second one found that the patients did not use an app to help guide their program, and their compliance was not very good and did not have any effect on SRS-22. The third study showed that kyphosis was improved and that the range of motion and the sacral angle were also improved. And then Romano found that bracing may be decreased by using exercise. And there was no difference, however, between the groups, but both groups improved their plumb-9 measurements, and a few more were improved in CS than in the control group. The quality appears to still be an issue in the kyphosis category, and so the key points are highlighted here for future research and should be addressed. So putting things together, we find that there's moderate quality evidence, mostly from short-term studies, but that includes some high-quality studies, even up to maturity, demonstrating positive effect for AIS. And there is some moderate to low-quality evidence for the effect of exercise for kyphosis, less so from PSSE in this domain. So we need continued research following our standardization guideline to demonstrate the longer-term effects and to see if we can detect individual by screening and then treat them, see if it helps prevent further issues. So I want to thank you for your attention, and I'll be happy to take additional questions.
Thank you very much, Eric, for your presentation on a very important aspect of the evidence for PSSE. We do have a number of different questions. One of the first ones I would ask is that there were several people that indicated that they were having a hard time reading some of the slides. Will your slides be available for them if they're requested in a PDF format that you can send to them?
So the best strategy will be the recording of today's webinar will be made available on the eSOSORT website. And so this will be announced in our newsletter. And then we can have an attachment available for people to download the questions we can't get to in this live session. And then we can also offer attachments of the different presentation. I can confirm mine can be made available.
The next question is not an easy one in the sense, I mean, as you indicated in your last slide, the conclusion is we need more evidence, we need more research that's be done. So the question is since 2015, we've had 10 systematic reviews. What could be the title for the next one? And where can we find the most urgent lack of information that we have, in your opinion?
I concur with the US task force when they did their review to determine whether they needed evidence for supporting screening recommendation. If we want to really offer an alternative for patients that are detected early, we need to demonstrate that if we treat adolescents with the right kind of curves in their adolescent years, how does that translate into adulthood? So at the moment, we have very few studies that would see the effect of treatment in adolescence into adulthood. So that would be very important. It's very hard to do, but I think it's something we should try to do. And even if it is just by doing solid database work with our routine clinical care, offering that evidence would serve a purpose. So I think it would be valuable. The RCTs would be very hard to do for that question, but it would be valuable. So in screened adolescent, it would be important. And generally speaking, we need studies of longer duration. So even within adolescent, at the moment, the majority of our studies, as we illustrated, are either short, few weeks sessions. So we would need multi-year or at least until maturity for our patients, as some of the studies now have shown. In bracing, we need to do the equivalent in exercise. As for the title, I would say for future systematic review, I think one way to bring things together would be to, because our literature on exercise is really published in many different languages, the reviewers have a harder task because these studies maybe require a little bit more legwork to find, and the reviewers need to find ways to translate these different studies. They can be good quality even if they're published in another language. And so there's value in trying to pool this evidence together from different sources in different languages.
The next question, again, is not the easiest one that's on the list. In terms of, PSSE includes a wide range of various different methods and approaches. And in your practice and in your research, is there any of them that have shown a significant difference in the overall recovery or correction of the spine deviation of your patient?
I think we're still at the stage where very few of the methods have been compared head to head. And so if I try to answer what's worked for me, it would really reflect more what I got trained in as opposed to what I know works best, because I don't have necessarily experience with many different alternate methods. And so we do have good evidence about a variety of methods. We don't necessarily have head-to-head comparisons of what they do in relation to one another. In that capacity, I'm not sure that I can take a stance and say this method works better than another one at this stage with the evidence we have. The other aspect of that question is that we're starting to see published methods that were not necessarily recognized as PSSE before, but when we apply our list of criteria, do they ask patients for autocorrection? Do they teach the correction according to curve type? We're starting to see variation. So additional methods described as scoliosis specific. If anything, it is blending as well. Some people propose their method, which is reflecting of a blend of different approaches, but they're scoliosis specific when you analyze them.
Yeah, and hopefully someday we'll just get to the science behind the physical therapy and not have to define a particular method and apply it in that way. Now we'll throw you an easy one to there. We've been using the term hyperkyphosis. We've been asked, could you please define that?
In theory, it appears simple, but when we start comparing the studies, you find that the inclusion criteria of the participants in those studies are quite different. If I kind of summarize what I came across, is hyperkyphosis would be a kyphosis measured between T1 or T2 and T12 in excess of 40 degrees for some studies, 50 degrees from other studies, 60 degrees from other studies. The other criteria that is different among studies is some of them require a structural change where they would really demonstrate a wedging of a certain number of vertebral bodies, while some other studies were not demanding that criteria. So in the hyperkyphosis literature, we're dealing with a bit of a population definition issue. So we'll probably need to come up with recommendations. If not in terms of building the study for that, what we might need is reporting for separate subsets of the patients so that we understand whether the exercise work for different definition of the pathology.
Thank you very much. Thank everybody for their questions. And as we indicated earlier, the speakers will provide answers to those that we could not get to within the confines of this virtual session. Now we're going to move on to Dr. Donzelli. Dr. Donzelli will speak to us about the indications for PSSE. She is a physiatrist and a research coordinator at ISOCO, the Italian Scientific Spine Institute. She has 10 years experience in scoliosis conservative treatment with a number of scientific articles published in the field of spine pathology and scoliosis. She is a current member of the eSOSORT board and SRS non-operative committee.
Hi everyone. It is a great pleasure today to present about PSSE indication and eSOSORT treatment guidelines. I have nothing to disclose. This presentation is based on the recommendation made by the 2016 eSOSORT guidelines. They are freely available at the following link and they are very useful in everyday practice for clinical choices. Why do we treat scoliosis? Most of the eSOSORT experts were questioned about this, and here you can see the top 10 answers given by the expert in 25 eSOSORT consensus. As you can see, in the 8th position, scoliosis cup degrees, while in the first one there is aesthetic followed by quality of life, disability and back pain. The basic objective of scoliosis treatment include stop curve progression during the most risky period of life, puberty, prevent or treat respiratory function, prevent or treat pain, and improve the appearance of the aesthetic of the trunk. The guidelines distinguish between primary goals, which are the best possible goals in patients, and which are achievable depending on the baseline characteristics of the patient. When the patient comes to the first visit with more severe curves, the primary most important goals could be not achievable, and therefore we need some compromise goals. That comes when it becomes clear that it is not possible to reach the primary goals. According to the patient characteristics and cup degrees at baseline, there could be a sort of aim adjustment. The categories of adjustment are 3: low degree curves, moderate and severe degree curves. So the primary aim could range from remaining below 20, 30 or 45 degrees, and the secondary aim could range from remaining below 45 degrees or postpone surgery. So clinical choices are for sure guided by clinical and radiographical assessment, but they come also from the best available evidences, from clinical expertise, specific expertise, and also patients and family needs. Who need PSSE and when it is necessary to start specific exercises treatment to reach the best possible goal? So in this presentation, I will try to answer to this question. This table constitutes the way chosen by the expert to resolve differences among experts and to define what is completely wrong above the maximum over-treatment and below the minimum under-treatment. It is quite difficult to read, but if you pay attention, this table is able to give a guidance for treatment for every single situation we used to face in everyday practice. Patients with the curves below 20 degrees are considered at lower risk of progression. So the goals could be preventing further progression or attempting to avoid bracing in order to reduce the burden of the treatment for the patients and improve aesthetics and function. Therefore, the recommended treatment include observation, physiotherapy specific exercises in patient rehabilitation and soft bracing. Patients with the curves between 21 and 35 degrees are the most complicated to manage because they could have different risk estimation according to their age, risk score, and family or other prognostic factors to be considered. So the goals could range from preventing or improving the curve or avoiding bracing to ending growth below 30 degrees and still improving aesthetics and function. The list of treatment is longer as we could use different treatment to reach these different goals in such different patients. This is the most complicated category to manage with. For the most severe curves between 41 and 50 degrees, the most important goal is attempting to improve the curves or at least preventing progression. Ending the growth below 30 degrees is still an achievable goal, but if not possible, the secondary aim will be avoiding surgery. Then, even in most severe curves, aesthetics improvement and improvement of the function is still possible. Of course, in case of higher risk of progression for patient at risk 0 to 2, brace is required, and mainly the requirement is total time or full time. But then in those classes at lower risk for progression at the end of growth spurt, for example, around RISA 3 or RISA 4, there could be only aesthetics. Also physiotherapy specific exercises and inpatient rehabilitation could be considered. Finally, observation and surgery are other two potential options in those cases, respectively at very low risk of progression or very high risk of progression. As you have seen, independently on the baseline Cabet angle of the patient, then prognostic factors play a major role in decision making. And among these factors, we should include family history, proven progression, signs of decompensation, the flattening of the physiological thoracic kyphosis, short curves, back pain, an important impairment of the aesthetic profile of the trunk. The practical approach scheme shown in the tables provided by the guidelines has been developed considering treatment options as progressive steps in an ascending staircase, as you can see here, starting from observation to exercises, soft bracing, rigid bracing, super rigid bracing, and finally surgery. Today, I'm mainly talking about the first two steps. And first of all, there is observation. Observation is recommended when the risks are low or very low, when the diagnosis is unclear, patients are younger, or when an active treatment is not feasible and risks are still low or very low. The PSSE definition provided by the guidelines include all forms of physiotherapy with evidences on the effect in some scoliosis outcomes. The frequency of physiotherapeutic session in scoliosis patients could vary from twice per week to daily sessions because there is a slight variation in protocols among different schools. eSOSORT recommendation regarding scoliosis-specific exercises with the goal to prevent progression include the 3D active self-correction based exercises with scientific and demonstrably effectiveness approaches and provided by specifically trained physiotherapists. Therapists should work in a team with scoliosis experts. Exercises must be individualized to different patient characteristics and regularly performed. There are some important differences from scoliosis-specific exercises and conventional physiotherapies, which relate with the complexity of scoliosis deformity, which is three-dimensional and which required an active self-correction, which must be three-dimensional too. The personalized approach, the need for follow-up, and in order to work in a team and provide timely intervention are among the most important characteristics which distinguish PSSE from conventional physiotherapy. The definition provided by the guidelines regarding active self-correction include both extrinsic and intrinsic, which is in practice a sort of facilitating way to achieve the correction compared to a correction achievable without any external aids. The role of sports activity is strongly highlighted by the guidelines. Sports activity are very helpful for growing subjects, but also for other subjects. But sport cannot replace scoliosis-specific exercises. So the recommendation is to combine sports activity with whatever treatment is needed. Coming from the available evidences, there is a recommendation for the association of scoliosis-specific exercises prior and post to surgical intervention. Scoliosis-specific exercises cannot replace bracing when a brace is needed, and this is recommended not to use exercises alone for curves exceeding 25 degrees, but physiotherapy-specific exercises are recommended to be associated during brace treatment because the therapist has a pivotal role in enhancing compliance and in providing different exercises according to different treatment goals in different phases of the brace therapy. Thank you very much for your kind attention.
Thank you, Dr. Donzelli. We do have a few questions. The first question from Nicola Raku is, will there be any changes in the management of scoliosis after your last natural history study?
Thank you for the question. I want to generalize my answer to all the prediction model have already been published or will be published in the near future. The problem is that we have some factors to keep attention when we have to decide what is the best treatment for our patient, but then we still need something more accurate. So when we try to develop prediction modeling, we are trying to find out specific factors much more related to different characteristics of the patient, because scoliosis could vary a lot, so there could be so much different characteristics in our patients. Expertise told us that some particular characteristic could be important, like the wedging of the vertebrae, vertebral rotation, the aesthetics of the trunk. This comes from the expertise, and we just learn while practicing and visiting a large amount of a patient, because in the beginning is still every time the visit ends, it's panic. What can I do for my patient? Because we want to do the best for our patient, but it's really a challenge in everyday practice. So this natural history study, we hope, will give a little more precise indication to the clinicians to deal with together with the final decision for our patient.
You indicated in your presentation about sports leisure with your patients. What is the one that you advise them to do? What physical activity do you advise your patients?
We are living in a pandemic. I don't know how it is in the other countries, but here it has become a challenge to practice sports because everything is closed. We are asking to our patient to perform whatever they can into their home, in the living room or wherever, in the terrace outside, in the background, wherever. Because moving and practice sport is very important. Now we are living in a period in which we move less than normally, and we were already moving too less compared to the need of human beings. And whatever sport they like, it is important because they can improve coordination and they can grow healthy. Sports is not a treatment, but is essential to be associated with the treatment for healthy in general. So the recommendation is to perform sports. And nowadays YouTube channel can provide whatever sports we can do. And I suggest to do whatever they like and they find time to perform at home.
What would you say is the most appropriate age in terms of young children to have PSSE?
It depends on the techniques, but they generally require a lot of attention, coordination. After 8 years of age is the best moment in which they can perform very precise exercising. Then, if done earlier, I think that parents and patients should be aware that the exercises will not be very precise and specific, and they would have to. On the other side, sometimes I suggest to delay a little bit the beginning of exercises, and this is why observation is a good treatment to be considered, because our patients have a long path of treatment, and if they have been diagnosed very early, then they will have longer path than the others. So sometimes we need to reduce the load of the treatment in order to maintain their compliance, because we will need, in the most difficult period in which the risk will be higher, which is puberty, we will need the 100% adherence to the prescribed regimen, whatever it will be. So it is also important to avoid to spend too much energy in the beginning, because mothers want to prevent, but sometimes beginning too early could be not the best choice.
Thank you very much. In the interest of time, we're going to have to move on, but we thank you for the presentation and for all the questions. Again, Dr. Donzelli, and we'll take the time to respond to your questions that we were not able to get to for today. So now we move on to next presenters, actually our roundtable. So I'm going to present 4 of the presenters at the same time, and then we'll go into their presentations. The first of those will be Tony Betts. And Tony Betts is a highly specialized physiotherapist with 30 years of clinical and teaching experience. He worked for 15 years with Dr. Menmita at the Royal National Orthopedic Hospital and has helped teach and expand the side shift program. He is an honorary spinal teacher for University College of London. Michele Romano is a physiotherapist and a eSOSORT past president. He is a co-founder and physiotherapy director of ISICO, that Italian Scientific Spine Institute, and the founder of the CIAS PSSE approach. Michele is the author of the Cochrane Systematic Review on Exercises in Adolescent Idiopathic Scoliosis and a number of other scoliosis-related scientific publications. Our next speaker then will be Andrea Lobel, who is a physiotherapist with over 35 years experience as a practitioner, researcher, and international lecturer and educator. In 2008, she founded the Scoliosis Physiotherapy Center in Canada, where she treats patients of all ages with PSSE methods she is certified in. She has mentored and taught physiotherapists around the world, authored papers and case studies, and co-founded the Scoliosis and Spine online learning platform to deliver online learning to healthcare professionals in the field of scoliosis. She has been a eSOSORT member since 2009 and is currently the secretary of eSOSORT. And last but not least is Dr. Sonia Schreiber, who is a clinician and a researcher whose research on PSSE for scoliosis won multiple awards. She is an adjunct professor in the Department of Physical Therapy, University of Alberta, an international ISST Schroth instructor, and an owner of a specialized physiotherapy clinic for scoliosis, Curvy Spine. She volunteers within the eSOSORT Board and Education Committee, as well as in various scoliosis-related activities in the community, and she has no financial disclosures for this webinar. With that, we would go into our presentations, starting with Dr. Betts.
Hi, my name's Tony Betts. I'm going to talk to you today about the trunk side shift approach. I have nothing to declare. Does it follow a logical decision-making process? And the answer is yes. What do we try and do? We try and raise awareness of the spine deformity. We try and look at the ability to actively self-correct in different planes. We try and assess those, analyze those, and follow it through. We try and provide support and education to the family, and we try and encourage adherence to brace wearing. We make sure that people use diaries, that we're aware of their ability to move. We assess the spinal deformity and look at its ability to correct. Does it follow a standardized assessment form? Yes. Obviously, the first thing we do is follow through the principles of good orthopedic assessment, and then we follow that with curve-specific assessment. We have multiple forms that look at the assessment from different angles, that look at hypermobility as well as rotational deformities of the leg, that try and relate that to the function, that looks at core stability and assessment and tries to score them. We use that and follow through a logical pathway to assess and decide in which plane and which movements we can correct the scoliosis. Is there a treatment criteria? Yes, there is. It's curve specifics, it's related to the cob angle, it's related to the 3 different planes. We're trying to overcorrect specifically in the coronal plane and complement that with correction in both the sagittal and in the rotational plane, as well as looking at the head position over the body. We follow through those principles and we make sure we apply counter pressure depending on what we find during our assessment form. Is there exercise prescription? Yes, and this exercise prescription is progressive. It's based on 3 stages. Once we've decided what the curve is, we'll provide the patients with the different information on that, and then we'll decide, let's first teach them what the fundamental movements are, make sure that they can do them correctly and maintain them. Then we'll progress to make it more difficult in terms of complexity of movement, in terms of when they're doing it, during everyday movements, during activities of more complexity, sports, and during maybe some specific movements and gym activities that they do might be functional, could be core related, and we'll integrate those when the patient is ready and able to do all of those and it's safe and easily applied. Do we integrate telehealth within it? Yes, we do, and we've started to do that a lot. We have a principle which says face-to-face first to make sure that we know what the patient's physical signs are. wherever possible, and that we can guide and give the fundamental corrective curve counter pressure movements against their curve characteristics. Once we're happy with that, we'll try and follow that up quite quickly, trying to make sure that they're doing it accurately and got good compliance. That might just be a 5-minute call within a week. We'll then follow that through using any forms of the technological platforms there to guide us and to work through. And we'll follow that through into their everyday movements, into their home environment, and we'll try and make sure that they're effective and able to do that. That is the side shift approach. Thank you.
The clinical decisions are conditioned by radiological, clinical, and motivational assessment. The complex of these evaluations will be the common thread driving all the choices made to organize an effective treatment. The effectiveness of conservative treatment with the prospect of long duration depends on two elements connected and interdependent. The method's ability to modify the natural history of the disease and the patient's adherence to the prescriptions. A method can be considered effective because some publications have shown its ability to slow down, stop, or in best cases, to reverse the evolution of the pathology. Still, if this method is not able to stimulate the patient's compliance, we cannot really consider it effective. The SES approach, the treatment method I use, includes a series of standard tests necessary for the identification of the treatment tools. The first indications are collected with the measurement of the three-dimensional deviation of the X-ray. Other informations will be drawn from clinical trials. The choice of the correction will be determined by a combination of this data, the use of table and algorithm suggesting the best theoretical correction, a practice test to verify if the patient is able to perform and keep the chosen correction, the final decision taken by the therapist. The treatment programs will be combined with the correction of curves and the group of exercises useful to stabilize it. According to the SES point of view, stabilization does not mean keeping the correction fixed. This represents a dream. But training the ability to use it in the daily life. As already mentioned, increasing compliance is a treatment element, not secondary to the effectiveness of the method. The program therefore will have to strive to use strategies to reduce boredom and make the patient feel involved in the decision process. The patient must perceive that he is not only the actor, but also the director of the chosen treatment. To increase the patient's motivation, a series of tricks can be used, which must also make the patient feel that he is not only one of the many cases we're treating, but that the choice of the treatment is absolutely individualized. The concept of exercises in the SES approach is substantially different from that used in other methods. In SES, the exercises do not represent a strategy to achieve the best possible correction. Instead, the exercises are the extraction and a challenging tool to increase the difficulty of performance and management of that specific correction, identified as the specific one the patient is actually able to perform during the activity of daily living. Therefore, from this point of view, the best correction is not the one that realigns the most, but the one that is most easily managed. Ultimately, the exercise represents the training in the use of correction. The choice of exercise, therefore, will be conditioned by the individual skill of patient. Two simple exercises do not train this skill. Two difficult exercises cause the loss of correction and the impossible achievement of their real goal. During the most critical phase of the pandemic, our institute quickly converted itself into a digital institution and organized new protocols to execute remote medical examination and physiotherapy treatments. The most significant tools have been the creation of home assessment tools, preparation of tutorials for families who have learned how to use them, for testing under the guidance of the healthcare professional. Then, the creation of phone application for recording the treatment program taught by the therapist via camera and supported by an assistant. After the first difficult moment of panic and uncertainty for the future, within a few weeks, thanks to these tools, we were able to make patients feel our presence even from a distance and not make them feel abandoned, recovering most of the treatment of all our patients. We have published 2 articles describing this experience. Today, in our clinics, telemedicine and telerehabilitation are not the most requested option, but an effective tool used with satisfaction even now by many patients who live far from the institute and who have discovered it. So, thank you very much. Thank you for your patience, for your attention, and see you soon.
Thank you for selecting me to take part in a roundtable session today. I'm a physiotherapist in Canada. I believe that good decisions are always based on scientific evidence, following regional and international SOSORT guidelines. The decision-making process is always patient-centered. It is not simple, and it takes into account several important factors that together play key roles in the treatment of AIS. To make this path easier, I follow a step-by-step approach to help guide me through the decision-making process with the patient and the family and the treatment team. The first step is awareness and support for the newly diagnosed patient. Education followed by a detailed assessment and an examination is fundamental. After all objective data and questionnaire results are collected, the decision will be based on a patient and family's goals as well as the treatment plan based on the physiotherapist's expertise. The treatment options are discussed with the treatment team and presented to the family. Throughout this process, the family is educated. Education can be happening many different ways. For example, they can visit their local scoliosis resource centers, visit educational website for more information, read journals, publications, and connect with other families who've gone through similar journeys. After the family provides informed consent, we can begin physiotherapy sessions. The decision-making process cannot be rushed. The goal is to achieve the best possible clinical outcome and meet the patient and family's realistic expectations. The initial assessment of the patient includes mental health, pain status, functional status, and self-image questionnaires, as well as other forms completed by the patient prior to their first appointment. During the initial visit, the physiotherapist conducting an interview with the patient and their family, gathering information on the patient's full medical history. During the clinical assessment, objective measurements are collected. Since the AIS is diagnosed of exclusion, a full neurological assessment is also conducted. Thorax and breathing function is assessed, as well as the X-rays and other imaging. Treatment criteria. Is the patient a good candidate for PSSE? This will be determined based on the initial assessment after all the objective measurements have been collected and the diagnosis of AIS has been confirmed by exclusion of all other conditions. All red flags are removed by further screening, investigation, and testing. Informed consent to treatment is obtained and the treatment plan is discussed with the patient and their care team. Every young person should have the opportunity to make informed decisions with the involvement and support of his or her family. Exercise prescription. The role of the physical therapist, who is familiar with one or more PSSE methods, is to translate his or her knowledge into patient-specific exercises using the best available evidence to ensure the best possible outcome for the patient. Treatments are individualized based on the curve types and the patient's sagittal profile. Also depends on whether the patient is being observed for progression, is an in-brace period, currently wearing a brace, or perhaps discontinued bracing, waiting for surgery, or even being post-surgical. We teach PSSE exercises using imagery, photos, and mirrors. All PSSE can be modified to the ability and the need of the patient at any given time. Teaching the patient postural awareness, active self-elongation, and postural correction in front of the mirror is the first step. The patient is educated on their unique curve type and the 3D nature of the condition. Photos are taken from the back, front, and sides to assist the patient's understanding of the three-dimensional correctional positions and how to perform the exercises. Teaching the patient supine and upright functional breathing exercises is a critical part of the treatment to improve the scoliotic posture and to reshape the torso. We also check the sleeping position, the range of motion of the extremities, and prescribe stretching exercises as needed. Gait and balance training is part of the dynamic PSSE exercises. Curve-specific home exercises are taught to the patient and the supervising parent. Home exercises are monitored online by the physical therapist and or by the family members. Telehealth is not a new service, as we have been providing online sessions for many years now. I have treated many patients via telehealth, especially over the past year, and many patients have benefited from the service, especially those who live far away. There have been several documented patient case studies showing improvement even without in-person treatment. Video conferencing will be added to our treatment options even post-pandemic, as it gives our physiotherapists a great way to check how the home exercises are performed. Despite the complexity of the decision-making process, it is always important to listen to our patients and recognize that aesthetics is the most important goal for the patient, which is achieved by one breath at a time. Thank you for your attention, and I'm happy to answer any questions you may have.
Hi everyone, I'm Sanya Schreiber and I'm your chair for today's eSOSORT webinar. I hope that you still have some energy left to listen to my last presentation for today. I'm super excited to be here with you and talk to you about short PSSE protocols. These are my disclosures. When it comes to making decisions about the treatment of adolescents with idiopathic scoliosis or hyperkyphosis, we need to understand that that is not a static process. It is more on a continuum. What we are trying to achieve is to inform patients and parents about specific spinal deviations and how they affect their posture. And we are also trying to provide scoliosis-specific assessment and finally treatment that is going to be delivered by trained specialists in order to achieve the main objectives of the treatment, which is to avoid surgery, prevent progression, or at least slow it down, and also to improve secondary outcomes such as chest mobility, respiratory function, trunk symmetry, and cosmetic appearance, as well as we are trying to also develop the specific home exercise program, and if brace is indicated, we want to support the brace treatment as well. The assessment is standardized and is scoliosis or curve specific, and is also supplemented by traditional orthopedic tests. We also assess risk of progression and conduct a thorough clinical and radiological assessment. In our clinical assessment, we would try to understand what are the functional and structural components of the curve using specific curve flexibility tests. Clinical assessment is followed by the radiological assessment, where we are trying to understand better pathology of scoliosis or hyperkyphosis. Finally, the information that we reach during our clinical and radiological assessment will guide us to a specific Schrott classification. Once we have reached to a specific Schrott classification using our clinical and radiological assessment, we will proceed with patient education, where we will teach the patient Schrott terminology as well as body blocks, because this is what helps the patient to understand better their specific curve and how that affects their posture, so that they can understand better how to perform their specific exercises. Finally, the therapy plan consists of 3 components: manual techniques that can be passive, assisted, and active, exercises that can be conducted in and out of brace, and postural training that primarily consists of adjusted activities of daily living. The treatment should be supplemented with thorough documentation consisting of specific examination protocol, therapy and radiological diagrams, as well as standardized photo series that are taken regularly at follow-ups. In addition to training books are given to the patients, and they consist of specific information about their curve and their specific information about the exercise treatment, as well as exercise logs so that they can track the progress of their exercises. The treatment is on a continuum and continuously being reassessed and re-evaluated during regular follow-ups with new x-rays and new clinical examinations. The exercise prescription is highly individualized. It is progressive, which means that it goes from more easier to more complex exercises. They follow specific structure of the exercises, and they are guided by Schrott classification, patient's abilities, specific patient's needs, whether a patient wears a brace, and specific patient goals. The exercises are delivered in 3D, aiming at 3D correction, and are supplemented by specific corrective breathing. Schrott exercises can be performed in and out of brace, and a home exercise program also consists of specific activities of daily living, including specific mobilization depending on the curve. With pandemic, telehealth has become more popular, and over the course of several years we developed 2 specific telehealths. One of them is a combination of in-person, consisting of initial assessment being in-person and follow-up sessions delivered on telehealth. And the other one is full telehealth, including the assessment, where the assessment is conducted by asking a patient to perform series of movement, and the follow-up sessions are instructed over telehealth. What we learned from SHROT telehealth is that it requires a unique set of skills by a therapist, because a therapist is required to educate a patient only using words without ability to touch a patient or provide any manual guidance. Some pros of telehealth may be that it's safe, it is convenient, it is accessible, and it's also cost effective. But cons are that it's more challenging both for therapists as well as patients. There may be some technical issues. It's not for everyone, and it's certainly not hands-on. We were recently awarded a grant to investigate the effect of SHROT exercises delivered via telehealth. So we are very excited to be able to learn more how we can improve the SHROT telehealth. Thank you all very much.
I want to thank all of the panelists for their great presentations that were given. While the other questions are coming in, I did have a question for all the panelists in terms of what have you found to be the best method that you use to determine whether or not the patient is actually compliant?
A simple method is their ability to accurately reproduce their movement upon instruction, really, in terms of their compliance. Can they reproduce it accurately and effectively? And then we've tried to introduce things like diaries, both video and personal written, to try and review compliance.
For me, the compliance is a very, very important element of the treatment. It is possible to use several tricks to increase the compliance of patients. One of these is to promote the feeling of the patient that he is not one of the patient, but this is a special one. It means that the treatment must be individualized, absolutely individualized. Even choosing the number of sessions or the number of repetition of exercises. I try to use different numbers, even if the case is the same, because I need that the patient feel he is special. And also a very important element in my idea is that the patient must perceive that the treatment is organized in combination. Me and the patient will decide how to organize the treatment. Obviously, the treatment is organized by me, obviously, but the patient must perceive that the decisions are not my decision. My decision is not in order. We decide together.
While we have you, Michaela, there was a question for you regarding the appropriate starting position at the beginning. What advice would you give practitioners?
In my normal working day, I use with my patient at the beginning the sitting position, because the sitting position is the easier one. The lying position is easier, but I don't use this position for the treatment. So I start by the sitting position.
Which brings us to another question from, I think, our friend Peter Loon. Is the advice to promote active sitting or facilitation of sitting in an active way and avoid any passive slumping or sloughing sitting part of your policies? It is all-day exercise?
Thank you. Yes, definitely. When we think about PSSE, physiotherapeutic scoliosis specific exercises, one of the components in the protocol is to get the patient to use these corrective movements in everyday life. So the exercises are motor control exercises, whereby we are trying to get them to learn the movement, different movement patterns that are going to be pushing them outside of their curve. So the short answer is yes, we are promoting so-called active sitting, also different ways of standing, so that they are always trying to be outside of the curve. So this is one of the parts of the treatment as well.
We do have a follow-up question for you, Sonia, and that is, which curve flexibility test do you use to determine the structural versus functional nature of a curve?
So when it comes to flexibility tests, those are dependent on the specific curve. There are specific flexibility tests for thoracic curves and for lumbar curves. We have a series of those that we teach our students in the courses.
Andrea, question comes up in terms of how do you assess the psychosocial sphere in your patients? What are the communication and motivation tools that you use to increase the adherence of your patients? You went through a lot of them, but what do you seem to work to increase their motivation?
During the assessment, I assessed the SOS-22 forms as well as the family observation helps me to determine how seriously the patients are considering engaging in this program. During the treatment, I motivate them not just by asking them to perform the home exercises, but to bring a diary and a detailed schedule what they followed at home. The children, teens, or parents fill up the schedule and present it in each and every appointment as they come. They can email it, they can text it, they can verbalize it as well, but I do ask them to report back what was their home exercise plan and how frequently they performed the exercises and how well they performed the exercises. I will see at the follow-up appointment.
I guess the next question any of the panelists can answer in terms of, today telehealth seems to be something that we definitely need for this moment. Hopefully things will change. I think, Michaela, you indicated that you give it as an option to your patients. Do you see telehealth being continued in your practice as you go forward? And how often do you think patients need an evaluation at the office?
I think that even in the future, the tele-rehabilitation, telehealth will be used because we had the possibility in this strange moment of our life to discover this. Also, the patients discovered this, and we had the possibility to understand that it is a valid option. Is different, obviously, respect to the treatment in presence, but there is no really different. So we have the possibility in this case, using the telehealth to treat patients that live really far from us. In the past was impossible.
Kelly is totally right that telehealth gives us opportunity to reach further distant patient. But I'm just going to add that in our protocol, telehealth is actually one of the things that we are using on a consistent basis, and we'll continue using this because we want to be able to see how patients are performing their exercises in their own home environment. One thing is when they are in the clinic and when we have everything perfectly set up, but then if they are actually able to perform their exercises correctly at home, that's another question. So this is also a very important aspect of telehealth as well.
In England, I think the expansion of digitalization of healthcare means that it will be something here for the future. And we're sort of trying to review it in terms of how do we ensure that we get equal and good accessibility to everybody and ensure that not only the accuracy of their exercises, but also the fact that that everybody has, sort of good access to Wi-Fi, a good environment in which they can do their exercises in, and the safeguarding concerns and legal concerns and things like that. And I think there's probably a lot more to be done in terms of looking at how well telehealth is used. But I must admit, I've found that the adolescents in particular have actually enjoyed doing it in their own environment and have actually got maybe good compliance.
I think it's going to be the subject of many more research papers as we go forward in terms of looking at the comparison. And is that true in Canada as well, Andrea?
Yes, it is very much true. It is improving the accessibility to the specialized physiotherapist. It reduces the travel time. And right now, this is our only option during the pandemic. So we're definitely gaining a lot of experience of how to deal with the families online, how to deal with teenagers. They do enjoy it. And as well as helping them actually setting up the exercises by using our words or using our demonstration online, it helps them to precisely perform the exercises as required at home. So I think it's here to stay.
Well, clearly in this age of pandemic and what we've all experienced around the world, that's probably the best question to be left with. We thank all of you panelists for participating today. We thank all of our attendees participating. We thank you clearly for allowing us to be with you for an extra 15 minutes this morning or today, wherever you may be. We truly appreciate coming to a close in this eSOSORT 2021 pre-conference, and we invite you, please, to go to the sosort.org website and join us in the virtual meeting that will be coming up on April 29th to May 1st. And we definitely all look forward to hopefully a physical meeting coming in for the SOSORT 2022 in San Sebastian. That will be a time when we'd like to all get together, and as much as telehealth may become part of our life, it still is good to hug. So we look forward to meeting you and seeing you, and we thank you for today. Have a wonderful weekend.